Okay.
Okay. So
Can you see my mouse in case I want to highlight?
Yes.
Okay, cool.
Yes, I can see it moving. Yeah. And yeah, we can start now if you like. Okay.
Sure.
So thank you so much everyone for coming in. Good morning and good evening, Robbie, from your end. Thank you so much for joining us from New York and doing this that late. Thank you so much, really appreciate it. So thank you everyone for joining us today. Today we are having Dr. Robbie Parks from Imperial College London. Robbie has got his PhD in environmental epidemiology, and his primary interest is in understanding the impact of climate, weather, and air pollution on mortality and disease outcomes. Robbie today gonna take us on, gonna present for us a paper that he recently published and co-authors. The paper was just discussing the particulate matter, air pollution, and the life expectancy in USA. Thank you so much, Robbie, for doing this, and we're really looking forward to hear you today.
Well, thank you, Mona, for the introduction. Hi, I'm Robbie Parks, and I'm currently in New York, and it's probably a lot colder than it is in Sydney. But, nice to be in touch. And today I'm going to talk about the paper that we had published this year, which is a study of the effects of particulate matter of 2.5 micrometers or less, or PM 2.5, on mortality and life expectancy in the USA. And there are a team of people that you could probably see in the presentation. So first of all, just like to acknowledge everyone there. And you may or may not know some of those people, but Majid Azati, the last name, he was my supervisor for my thesis, for my PhD that I've just finished. And so I'm particularly grateful to him. In terms of how the presentation is going to go, it's fairly relaxed. I'm going to just go through the slides, and either you can ask questions at the end, or if you want to ask in the middle, there's also fine. As a background, as Mona said, I'm an environmental epidemiologist, so I wasn't involved in the production of the exposures, the PM 2.5. So that's just part of, that probably contextualizes what I contributed to this paper. And so you can see the paper here. I've got a link at the end, which is like a short link if you want to take it. It was published in PLOS Medicine, I think, early this year, in April, I believe. And so just as a brief background for the very start, what is PM 2.5? This is a handy diagram from the EPA website where you can see that PM 2.5 fits 4 times into PM 10, and that makes sense because it's a quarter of the diameter. And you can see that it fits many times on a human hair, and PM 2.5 is smaller than PM 10, and therefore it can penetrate further into the body. So it has many well-documented impacts on health. And in this paper, we focus on cardiorespiratory health. And so as a background, other studies that have happened before, you can see on the screen right now, time on the x-axis and PM 2.5 on the y-axis, and this is the mainland United States. And you can see each of the black dots at each year is a county in the United States. And so you're seeing a distribution over time And there's a big gap between 1980 and 1999. So in the years 1979 through 1983, the US EPA maintained a network for research purposes. And so that's why you're seeing a cross-sectional PM 2.5 measurement profile in 1980, but that didn't happen nationwide in a consistent annual way until 1999 onwards. And what you can see is that over time, the standards which was set by the EPA of 12 micrograms per meters cubed was gradually gone under by all counties in the USA, but about 10% at the end of the study was still above the WHO standard of 10 micrograms. And about 89% of counties at the end of our study period, which is 1999 to 2015, had concentrations of PM 2.5 from 5 to 10 micrograms. So just over here. And so there's some famous cohort studies which take a selection of people who I won't go into detail about cohort studies, but essentially a subset of a population, and they're following closely how their exposures are at a particular time, and using the variation spatially in exposures, how that explains the differences in life expectancy and death rates in the United States. And so there's several high profile ones there. For the Medicare cohort study, which I'm highlighting here, that was one of the ones which happened using data after 1999. But for a national study, these are cohort studies, a national study, there was a research gap for using this spatial and temporal PM 2.5 data set to try and understand how the PM 2.5 changes and the remaining PM 2.5 above the lowest levels in the USA had impacted upon life expectancy. And PM 2.5 monitoring began in earnest for the EPA in 1999 and continues to this day. And just as an overview, for the United States, there are about 750 monitors for every year, or 750 monitors or more from 2000 to 2015. And during that time, from 1999, there are about 600, and it got up to over 1,000, but there are always more than 750 from the year 2000. So that's just a brief overview of the PM 2.5 data. So I just explained that a lot of the high profile studies into life expectancy discussed results from cohort studies. There are population-based studies where you use the entire national vital registration mortality data, such as in the USA, which we did, which looks at every death in the United States, or a subset of such as with Pope et al. And Correa et al., where they tried to understand the impact of how reduction in PM 2.5 can explain the change in life expectancy over time. And these are direct estimates. So what you're seeing on the left-hand side is taken from the New England Journal paper by Pope, and you broadly see that the reduction in PM 2.5 over time for each county where the circles are metropolitan counties, as reduction in PM, the greater the reduction in PM 2.5 over the time period, the greater the change in life expectancy. But these were only for a subset of all the counties in the United States, so they're metropolitan counties. So you also have Fan et al. In 2017, who used the entire population. This study used the entire population of the United States and all the death records, but they took off the shelf, as I understand, off the shelf risk estimates of PM2.5. And so the risk estimates from that paper was not generated by the data that they used in the paper, but rather from a previous study. So what we did instead was to take the data from the exposure and the outcome, and then generate risk estimates, and from our own risk estimates, generate changes in death rates and then life expectancy via life tables. So that was our aim, essentially, to be the first direct population-based study at the national level, using the data that you can see over on the right-hand side of the time series for PM2.5, where each dot is a county again. And so using that data, we could therefore estimate age-specific numbers of excess deaths and the loss of life expectancy due to PM2.5. And just to talk about the data we used itself, we started in 1999 for two reasons.
Hello.
And so it was a convenient matching, because when you went from ICD-9 to ICD-10, there were potentially discontinuities in particular causes of death counts. And so we went from 1999 to 2015. Our outcome was deaths by underlying cause of death from vital registration and population from the census. So we divided the death counts in each county in each year by the population in that county to obtain a death rate. Our exposure was annual mean PM2.5, and that model is detailed elsewhere, but the pollution data set was produced by the Center for Air, Climate and Energy Solutions, or CACES, which we used as a novel data set for the United States. So just as a brief overview, it's an LUR model simulating observations in the universal Kriging framework. And we included other covariates which may have, which would have been relevant for the change in, first of all, the variation in death rates between counties spatially, but also over time, how these counties changed in their death rate, other factors other than PM2.5 would be relevant there. So we covered percentage poverty, percentage black, a measure of education, percentage of household graduate, urbanicity, so the percentage living in urban areas, percentage unemployed, per capita income, and age standardized lung cancer death rate as a proxy for smoking, annual mean temperature and annual mean relative humidity, confounding factors on an environmental basis. So I'm just getting a bit of feedback, but I'll try and continue. If everyone can hear me okay, I'll continue. But I'm just trying to continue through the quite loud noise I'm hearing. So I might mute myself and then, sorry, I might mute my, oh no, it's gone now. It's gone now. Okay, so this is a summary table. The outcome you can see as exposure, annual mean PM2.5, and the covariates here. So they're explained in detail there for reference, and the sources of data are on the right-hand side, on the rightmost column. So from a variety of places which are detailed in more detail in the paper itself. And so what did the data for PM2.5 look like from 1999 to 2015? So we can go through each quarter of this figure taken from the paper in turn. So the top left is the PM2.5 in 2015, and you can see there's quite strong spatial variation. The lowest in 2015 was, I believe, in Arizona, a county called Apache County, and in California was the highest at 13 micrograms. And you can see that peak sort of here. The distribution of PM2.5 in 2015 is also shown as a histogram here, and you can see that there's a mean at around 7 and a distribution which is normal-like around that, although it's not quite. And you can see that the maximum, which corresponded to this value here on the right here, and then Arizona, the lowest county was Arizona here. And what you also can note from the bottom left and the bottom right is that largely the rate that the PM2.5 was, the greater the PM2.5 was in 1999, the greater the reduction was between 1999 and 2015. So, for example, in the very extreme top right of the bottom right diagram, PM2.5 was very high, above 20 in this county, but its reduction was the highest of all the counties. And so this quasi-linear relationship shows that fact. So the greater the PM2.5 was in 1999, largely the greater the reduction. So PM2.5 is going down, and the higher it was, the quicker it's going down. And I think there's been a recent trend of PM2.5 going back up in the United States, which is slightly worrying, I suppose. But up to 2015, it was broadly on a downward trend. There were a few counties which had gone up slightly in the top left of the map, and there's speculation as to whether they were to do with forest fires or other modeling assumptions where the uncertainty was large because of monitoring coverage, but also because PM2.5 was very low anyway. But it's worth noting there were a few counties, maybe 12 out of 3,000, which seem to have gone up slightly. And so just to talk about the study design itself, it's an ecological regression, i.e. we're overlaying collected population statistics for each county and associating them with an exposure, in this case PM2.5. We had a lot of county units, so in the United States there are 3,108 counties in the mainland or contiguous USA, which does not include Alaska and Hawaii. And because these changed over time, we needed to create a system which meant that we could use consistent county boundaries throughout the study period. And so that reduced our counties slightly by just over 20. And the third step in this, the second reduction of counties, or the third step in this logic here, was we went to merge counties. And the reason we went to merge counties was because calculating life expectancy or death rates in areas where they had zero population was not possible. So we merged counties using an algorithm which allowed us to get more than 25,000 population for both male and female in all years in the county. And we only merged counties where they were consistently urban throughout or rural throughout, and they were also in the same state. So it wasn't perfect, but we reduced the number of counties by about a third, but it also meant we could actually calculate life expectancy. So we modeled the underlying levels and trends in death rate, as well as the effect of PM2.5 using our Bayesian spatiotemporal model. And we're estimating the effect of PM2.5 on cardiorespiratory deaths, assuming that other deaths are unaffected. So our change in life expectancy is purely attributed to the expected change in cardiorespiratory deaths due to PM2.5. And to do all this, we used Bayesian spatiotemporal model inference. And so I'll just go to the next slide first. Actually, no, I'll go back. So you can see here that we have 4 candidate models, unadjusted, covariate, and county, and restricted. And we allowed the log of the death rates to be explained in any county in any year for particular age groups and sexes by variation sorry, I'll start again. We allowed there to be variation by different means, but the sum of the death rates was summed from common terms, which looked at the change in death rates over time, as well as the death rates at the beginning of our study period. We allowed variation by county. We explained variation by covariates in some of the candidate models, and anything above that we attributed to air pollution. And so this gamma term is what most of the results will be focused on here. So out of the 4 models, we used the covariate and county model to address a lot of our, or all of our results going forward in the paper. And if you want to think about the logic of the 4 models, essentially you're gradually taking away the attribution to pollution of the variation between the counties. So in the unadjusted, you're essentially saying that all the variation between counties of death rate is due to air pollution, which you might deem as being optimistic in terms of how you would want the effect of air pollution to be if you're looking for a strong signal. And that varies all the way down to restrictive, whereby you're assigning the difference between death rates in counties to covariates, but also explicitly to any covariates you may have missed beyond the 9. That should be a 9 there, but beyond the 9 covariates which were used explicitly in this restrictive model, but also any others which were implicit over time here. So alphas are intercepts and betas are slopes. And there'll be another slide in a second which may make that a bit clearer if that wasn't clear up to this point. And so broadly, if you want to think about it, unadjusted is the most optimistic in terms of attributing death rates to air pollution, or differences in death rates to air pollution, and restrictive is the least optimistic if you, or you might say it's over adjusting. And so we judged that covariate and county was an okay compromise between the 2, but we present all the results for analysis and interpretation. And so our analysis was done by age group and sex separately. So each age group and sex combination was performed separately in INLA, which is a Bayesian spatiotemporal package in R. In all 4 of the models, the log transformed death rates, which you're seeing here were modeled as a sum of the components that depend on time and air pollution. So the death rates for a particular county in a particular year had a particular universal value, which is essentially the average of all the county values in the United States at that time. And then those were allowed to change over time. And you are allowed variation for the intercept of the log of death rates by county. And you were also allowed variation due to covariates, which I had, which I had explained before, but I can refer back to those later if we need reminding. And then for nonlinear variation above and beyond, we included a random walk of order 1 over time per age group and sex combination, and also an over dispersion term which allowed for extra Poisson variation. And then beyond that, we have a pollution term here, which is gamma. And so that provides a relative risk estimate for every microgram, or in our case, we used a summary of every 10 micrograms increase of PM2.5. And that provides a multiplicative risk. And a multiplicative risk is due to the fact that we're using log of death rates. And the reason that we use log of death rates is to avoid negative death rates. If we didn't use log of death rates, it meant that if you reduced PM2.5 enough, then eventually you could potentially get a negative death rate. And so that's one of the reasons. There are other reasons also. And so in this specification, the coefficient of the PM2.5 term represents the logarithm of the proportional change in death rates for each unit of additional PM2.5 concentration. And you can think of it as akin to proportional hazard models used in analyses of prospective cohorts. So it's another way of thinking about it. And so these are the results from our models. And so what you're looking at is females on the left and males on the right. And each color represents a different model. And so you are getting the rate ratio per 10 micrograms of PM2.5 here. And so that means if, for example, let's say 1.25 here means that you have a 25% increase in death rates for a 10 microgram increase in PM2.5. And so that's how I would read the x-axis, and the y-axis are the age groups, which were grouped into 5-year age groups apart from 85 plus, which was open-ended. And the colors represent different model specifications, where there were 4, as I had described in the candidate models before. And you can see that there's variation between age groups. So its age seems to act as an effect modifier. And the largest increase is middle-aged adults here, and particularly women compared to men, because these are on the same scale. And we use, going forward, the green values. I should say that the lines are the 95% credible intervals of the uncertainty in the estimates for these rate ratios. So these are the effect size values for the cardiorespiratory deaths relating to increases in PM2.5, in our case, per 10 micrograms of PM2.5 increase. Now, what does that mean for life expectancy? Well, we can take these values and put them through life tables, and we can calculate the attributable deaths, and from the attributable deaths, we can calculate how many years of life would be taken off someone, or a life expectancy national estimate change due to PM2.5 under different counterfactuals. And our counterfactual we used was how many deaths were attributable to the fact that PM2.5 was higher than the lowest county in the United States in 2015. So the counterfactual is, if all the counties in the United States had PM2.5 levels as low as the lowest county, which was in Arizona, how many lives would be saved, or how many lives have been lost due to the fact that it's not at that level as it stands. And that county was Apache County, and you can see that, for example, the green is what we're focusing on in our results and what we quote. The PM2.5 was responsible for 15,612 deaths in females and 14,757 deaths in males, so around 30,000 deaths due to the fact that the levels of PM in 2015, due to the fact that pretty much every county was above the lowest value in the United States. And you can see there's a distribution of loss of life expectancy for the particular model which we quoted, the covariate and county. Here you can see there's a variation for females, and here you can see there's a variation for males around the average. And that's because in life tables you use death rates, and baseline death rates are higher in some counties and are lower in other counties, and broadly they're higher in counties of higher deprivation. So there is a variation around that, even though the risk estimate for PM2.5 is the same. And other interesting facts from the green loss of life expectancy, which is the covariate and county model which we use, the losses range from less than 0.05 years, which were in lower pollution Midwestern and Rocky Mountain areas, to greater than 0.3 years in and around Los Angeles and Arkansas, Oklahoma and Alabama, so the deep south, and California around Los Angeles County. Counties experiencing a loss of more than 0.2 years or more was about 15.5% for the female population and 8.5% in males. So just to say that again, counties, there are about 15.5% of the female population and 8.5% of the male population had lost 0.2 years or more of life expectancy due to the fact that PM2.5 in those counties was above 2.8 micrograms, which is the level in Apache County, Arizona, which was the lowest in the United States in 2015. And to show that spatially here, from the covariate and county model, which was the green in the previous slide, here you can see that there's spatial variation, and that spatial variation is clear to see in California, around the south of California, compared to, say, Nevada here, and you can also see in the Appalachian area and the Midwest that there is greater life expectancy loss due to higher baseline death rates in those areas. So what that means is the higher the baseline death rate is, the greater the life expectancy lost, and also the fact that it's a combination of two things actually. It's the fact that you had higher baseline death rates, but also the fact that the current PM2.5 levels are more above the minimum than other counties as well. And so you can also highlight how those counties would be by different level measurements of what we call deprivation. So county level life expectancy losses in 2015 from PM2.5 above 2.8 micrograms, which were split by covariate quintiles, so split into 5. And in the main paper, we did it by income and education, poverty measurements, as well as by Black or African American race. The broad picture is here. The higher the PM2.5 exceedance was in 2015, on the x-axis here, I'll focus on females, then the higher the life expectancy loss was in more deprived areas. So the greener colors were the more deprived areas. Here, well, actually in this case, they were the least educated as by this metric, but it is also true for higher deprivation or poorer counties. And so you sort of see a difference in the way that counties have lost life expectancy as a function of PM2.5 exceedance, but also as a function of the deprivation levels or poverty levels in those counties themselves. But we also can note that overall, life expectancy has improved in the United States, and it would be interesting to try and figure out what proportion of that improvement could be attributable to reduction in PM2.5. And so we also calculated the contribution of the change in PM2.5 during the period 1999 to 2015 to the life expectancy increase. Now, it's worth noting that the United States life expectancy increased for both females and males in this period, but had a recent reduction, and that matches also the fact that recently PM2.5 has gone up, but it would be for other reasons as well. Now, you can see from almost entire green map that there has been life expectancy gain due to reduction in PM2.5 from 1999 to 2015, which, with the exception of about 14 counties, or 14 counties exactly, where PM2.5 has increased slightly. And just to quantify the average, the gain in life expectancy for females was 0.17 years and 0.15 years for males. Now that compared to a total increase of life expectancy overall in the United States during this period of 2 years in females and 2.5 years in males. So about 10%, if you want a calculation, about 10% of the increase in life expectancy in females and males can be attributable to the reduction in PM2.5. But as the previous slide map in red shows, that there is further gains in life expectancy to be made by even further reductions in PM2.5, as I'm showing here. So red is bad and green is good here. Now, in summary, this study is, like any epidemiological study, is not perfect, and so you could see the broad advantages or strengths of this study are the fact that it's a national population study, so we're including every member of the United States or the mainland United States, which included every death in that period too, from 1999 to 2015. So it's the first kind of study of that kind, whereas other studies before had used subsets of populations or only particular metro counties in the United States or city-like counties. And we presented results for a range of models, and the data are all publicly available, so there's no accusation possible of secret science, which is sort of one of those topics that have been brought up recently by recent US politics, especially. But however, because it's an ecological population study, we cannot for sure establish causality, because there may be other factors which are likely to be completely correlated well with pollution in these counties, but also there may be other covariates which were not included, but the range of models, we hope, accounted for that fact. The PM2.5 exposure estimation is assuming strongly that there are exposures the same throughout each county. We know that there's going to be differences in indoor and outdoor PM2.5. We use lung cancer death rates as a proxy for the cumulative hazards of smoking in a population, and that's because previous studies have justified how using that covariate was a better predictor of lung cancer death rates. Was a better predictor of smoking rates in a particular location in the United States than a smoking survey itself. But again, that's not a perfect covariate to use. It was very difficult to allow for mixes of pollutants, so we did try to use more than one pollutant explicitly, so PM2.5 and something else, but that under our current model was not perfect and in fact was troublesome. And as I put here, it's both an advantage and a disadvantage that we put results for a different range of model assumptions, because first of all, it's an advantage to show that we've been completely open, but also it's also potentially debatable about which model may be the most reflective of the truth, and different messages can be derived from these models. And so as a summary, PM2.5 pollution in excess of the lowest observed concentration, which is 2.8 micrograms in Arizona, was responsible for about 30,000 deaths together in males and females in 2015, which resulted in a loss of life expectancy of 0.15 years in females and 0.13 in males. So that amount of life expectancy could be added to current life expectancies if PM2.5 went down to the very lowest level, which was 2.8 micrograms. But also in this time, similar values were gained in life expectancy due to the fact that PM2.5 went down from 1999 to 2015 for the vast majority of counties in the United States. And as I discussed before, about 20% of the gain of life expectancy roughly could be explained potentially by the decrease in PM2.5. And so that's the summary of the paper. There are lots of other discussions in the paper itself. You can get a paper link on the top. And if you want to find me on Twitter, you can via RMI Parks. But that will conclude what I had to plan to speak about for the morning in your time zone and the evening in my time zone. So thank you for listening, and I'm happy to try and clarify anything if it wasn't clear and take any other questions. Thank you.
Thank you so much, Robbie, and I apologize for the noise in the beginning of the webinar. Zoom wasn't allowing me to record when I mute myself, so I apologize. Just figure it out later. So I apologize for you and for the audience, and thank you so much for the interesting presentation. We're open now for questions, and yeah, like people can type in the chat. We can have a look at their questions, or they can easily unmute themselves and ask questions directly to Robbie. Thank you so much for being here.
Okay, I'm gonna try and find the chat just quickly.
Hi Robbie, this is Ivan. I'll just talk to you. That
Hi,
was great. That was really great, Robbie. That was fantastic, actually. I've got two questions and a comment, so I'll just go for both. Why did you use cardiorespiratory and not all-cause deaths is one. And the second is using the single county as the counterfactual. In similar work in Australia, we've been using a minimum for each region, because we've got really big regions. So like the Northern Territory burns a lot. Right. It's up in the tropics, and so we use a different counterfactual up there than we do down south. And my comment, just for people who wanted to know about the years. I think 0.15 of a year is about 60 days.
Yeah.
Yeah. And so I guess that's a challenge that we run into, is making sure that the message of years of life lost is clearly understood. Like, it's easy to understand the number of people, but when you start talking about days of life expectancy at birth that are between 60 and 70 days, and especially if you talk about them as 0.2 of a year or whatever, that it becomes hard to conceptualize. So thanks. That's my two questions, and finished with a comment.
Thanks. So the first, maybe it'd be easier to have a discussion, because I tried to write down the first question, but
it's just all cause seems to be a good disease category, because you use only cardiorespiratory diseases, but a lot of other causes of death might be related.
Yes, we used, I think we did a sensitivity analysis with all cause, and we found that the difference was largely explained by cardiorespiratory, and the reason we used cardiorespiratory therefore was that it was most strongly linked in the literature with PM2.5 association. So I completely agree that there would be other pathways for other diseases, but because the results were robust to splitting cardiorespiratory and non-cardiorespiratory deaths, and all cause, for example, getting a consistent result over those splitting methods, we decided to go for cardiorespiratory alone, which of course gives the assumption that all changes in life expectancy due to PM2.5 change would solely be attributable to the change in cardiorespiratory deaths. We accept that that is a strong assumption, but we decided to do that based on the literature, the weight of the literature being for cardiorespiratory. But we welcome any suggestions onto other particular causes of death. The other reason we wanted to use cardiorespiratory was also due to the fact that when we're dealing with small counties, there weren't necessarily smaller diseases, so there weren't necessarily enough numbers for subsets of cardiorespiratory disease. But I take your comment that we could have used all cause to present our main results. And your second question, if you could...
You used one county as your counterfactual, whereas in Australia we use one for every state and territory.
Yes. So in Australia, you said, for example, you would reduce the PM2.5 as a counterfactual to a level which was realistic in each state because of the nature of each state's environment. Is that fair enough?
Yeah, that's the assumption.
Yes. So I guess we just did it for parsimony. We don't have expertise necessarily in what would be realistic for each county, but that would be an interesting calculation for us. We call
them bioregions. They're actually like
bioregions.
It's a landscape effect. Yeah. And
so, would you have a suggestion as to how you would, or would there be literature which you could look at? One could look at for understanding how to attribute a counterfactual by a particular location. Because
we're mostly worried about the flammability of the forest type and how often the fire regime. But you could also be worried about dust.
Okay. Well, the only answer really would be for a counterfactual justification would be the fact that it was sort of parsimonious and illustrative of potentially how life expectancy can be improved by a real example of PM2.5, but we didn't take into account how realistic that real example was for different counties. So that could definitely be improved upon in that sense. So thank you for that comment.
Robbie, we have a question, actually a couple of questions on the chat. So if you If you are not able to see them, I'm happy to read it for you.
Sure, I can't see them, so that would be nice.
Okay, no problem. So we have first question from Michael. Michael is saying, really interesting findings and beautifully presented. Do you think that the effects in females are real? And could PM2.5 actually be protective in baby girls? What's going on in middle-aged women and men?
Okay, so I'm just, thanks for the questions. Thanks for, well, if I hadn't said before, thanks everyone for listening and thanks for your questions. It's nice to have people engaged in the work. So I think you're, Michael, if I'm correct, you're highlighting this area here, which is, I think for anyone even skeptical of PM2.5 wouldn't suggest that you would use PM2.5 to raise healthier babies by putting them in a higher PM2.5 environment. The speculation we have for that particular result is that there are covariates which we hadn't necessarily accounted for. So, for example, distance to hospital effects, which could be above and beyond, say, the covariate where we accounted for the percentage of urbanicity in a county, where you might think that in a urban environment or in particular environments, you may be nearer a hospital for treating a baby or young toddler with an acute cardiorespiratory condition. And so it may be more likely that you save that baby's life or that toddler's life by being closer to some hospital. And so just because you've got higher PM2.5 in cities, but you haven't necessarily explicitly accounted for the distance to hospitals, you may get this weird result that it is in fact better to have high, or not better, but the death rates are lower for higher PM2.5 areas. The short answer is, I don't really know, we don't really know, but I think we speculate that it may be something to do with urban environments and an effect above and beyond just urbanicity, the fact that there may be hospital distances. The second question is, do we believe that middle-aged, so for example, middle-aged, I believe you might want to call this middle-aged women and men, is it higher there, and do we believe it? I think the results are robust across all the models, that they're higher for those age groups than older age groups and for younger age groups. Do we think it's true that females have higher than males? I don't think we're necessarily the first to show it, but whether it's true or not, I would speculate it is, but the reasons behind it, I do not want to get into that, just because I think there may be someone better qualified to explain the biological processes whereby PM2.5 may affect cardiorespiratory health in females differently from males. So unfortunately, I wouldn't speculate there, but yes. So I hope that at least explains what we think it might be, whether or not it is real in terms of the female 0 to 4 is also, I accept, is an open question. And the males, although they do largely cover the uncertainty largely covers one there. So, but I guess one thing is that it is worth, it is potentially worth doing studies by age group and sex, just because you are noticing a differential in relative risk. And so if, as you often may do in particular studies where you don't account for the effect modification of age and sex, you wouldn't be doing anything wrong, but you may be missing a certain richness of effect differential where it may be available. So that would be my sort of broad message from this particular slide.
Thank you, Robbie. And I think we have another question from Jeff.
Sure.
Yeah, thanks, Robbie. That was great. My first question was along the lines of Michael's about the higher risks in middle ages and whether that is reflective of an underlying risk of cardiorespiratory mortality in those middle age groups, or because I suppose we assume that it's the vulnerable people who are most at risk. But anyway, that, don't need to go into that in more detail. If you don't want to, that's fine. The other question is, do you have any more comments about the strengths and limitations of these mega population level cohort type studies that have area level covariate data compared to the more traditional cohort studies that have individual level cohort data?
Well, thanks for the question. I wouldn't have a particular comment apart from the fact that I would suggest using both of them and hoping that they illustrate a result in the same direction. These kind of ecological studies are useful if you are very careful with the provisos that I had expounded in the talk, and also that they are to do with deaths. I'm talking about the results I've just described. They're to do with deaths which are attributable to changes in PM2.5 from year to year, so not necessarily cumulative effects which cohort studies would be able to uncover. So I would say these are really useful studies for incorporating massive amounts of data, but I wouldn't necessarily use them by themselves to try and illustrate a point to try and persuade a policymaker. Rather, I would use them as a sort of in part of a consortium, which certainly should include cohort studies. The advantage of these studies is that you don't have problems with data procuring. So all the data we have here is publicly available, and you include all the members of a population. But I fully accept the validity of cohort models and the ability of those to really define personal exposure well, if those studies are done well. So I would say they should be using it in concordance with, if they are in concordance with cohort studies, then it just adds to the argument that PM2.5, in this case, this exposure is bad. And so that would help, I think, in a policy framework, a policy context. So.
Yeah, thanks. And it's, an amazing piece of work with phenomenal amount of data. So thank you.
Thank you. Okay.
Okay, I think still have 1 minute, so I haven't got any more questions on the chat. So I think that's it then. Thank you so much, Robbie, for being with us today. Fantastic work. It was really informative and thoughtful. Thank you so much for being with us. And we're looking forward to have you more and more in 2020 with more fantastic work.
Well, thank you all again. Thank you, Mona, and thank you for listening. And I'd be very interested in further work that we could do together. And I wish you a great day. It's going to be a far warmer day in Australia than it is in New York. But,
yes, wish you.
Yeah.
good evening to you, and enjoy your night. And thank you so much again for being with us.
Thank you. Cheers.
Cheers. Bye-bye. Bye.
Bye-bye.